So as you can see from this first slide, we're going to be talking about tongue tie and its possible relationship to obstructive sleep apnea and malocclusion. I don't get money from anybody, though Dynaflex has been very generous in supporting a little study I'm doing, a pilot study on mandibular advancement devices for children. I start all my lectures generally with this little phrase from Star Wars Yoda, that you must unlearn what you have learned. Some of the things that we're taught as the golden rule or absolute truth, as you're probably finding in practice, don't really apply. So we know that ankylosing has been related to certain things such as speech impediment, breastfeeding issues, social mechanical issues, can't lick your lips, gingival recession. What we're going to talk about today, though, primarily is growth and development of maxilla and the mandible due to a tight lingual frenum and obstructive sleep apnea. So why are we talking about this? I don't know if you've had it in your practice, but certainly we get it all the time at Children's Hospital. People coming in and want the child to have the frenums taken out because somebody told them it's interfering with speech, it's interfering with breastfeeding. And so you can see in this study that was done between 1997 and 2012 that there was over an 800% increase in the amount of not only diagnosis of ankylosing, but the performance of frenums. That has actually increased exponentially, as I'll show you later on, in the orthodontic field. Just doing a little cursory, just as an example of how this has exploded, just going through the websites and so forth, advertisements. Just in my area, Baltimore, Washington area, there's over 24 both dental and medical practices that actually advertise that they're the tongue tie center. Even Johns Hopkins University advertise it. So what do these people believe is the reason, for example, in obstructive sleep apnea, that releasing the lingual frenum somehow is going to help obstructive apnea? Well, they believe in a normal posture of the tongue should be in the roof of the mouth. And because the tongue is attached more firmly in the front, they feel the base of the tongue is able to drop back more easily to occlude the oral pharynx. So possibly at the end of this talk, you're going to think that I don't believe that you should ever do a frenectomy. And that could be further from the truth. I think after a good functional analysis, after taking a good history, before we do any surgical procedures, any non-surgical procedures should be attempted. And doing my own small little clinical study, I know how difficult these are compared to animal studies, and that even though you can criticize maybe the small amount of number in these studies, they all do have a usefulness. So let's first talk about what we define, or what is being defined as ankylosing. So if you just go to Dr. Wikipedia, which actually has a fairly decent description, as I would call it. Ankylosing, also known as tongue-tied, is a congenital oral anomaly that may decrease the mobility of the tongue tip and is caused by an unusual short, thick lingual frenum, a membrane connecting the younger side of the tongue to the floor of the mouth. Then you get into the pediatric literature, and you can see this definition is ankylosing is the attachment of the frenulum to the tongue should normally be 1 centimeter posterior to the tongue's tip. One of the most common characteristics of ankylosing is a heart-shaped tongue, and I'll give you an illustration if you're not familiar with that looks like. And then you get this one from the Mayo Clinic, excuse me, I'm sorry, I got confused there. The Mayo Clinic, Mayo Clinic. The tongue tie is a condition where your child's tongue remains attached to the bottom of the floor of their mouth. Doesn't really tell you a whole lot. And then we get into Johns Hopkins, where the frenum is posterior, not visible when touching the area with the fingertips. The examiner can feel tight fibers anchoring the tongue with or without thickening. And some reason they put this in here, a shiny surface to the floor of the mouth. So as you can see, definitions are all over the place. If we look at cadaver studies, what makes up this tissue that attaches your tongue to the floor of the mouth? It's primarily collagen and elastin fibers, either type 3 collagen, type 1 collagen, type 1 or type 2, and they all have this elastic ability. And that's what makes it so difficult, for example, when I show you about measuring how stretchable this area is. And also in this area, there are a lot of nerves, there are a lot of blood vessels, there are a lot of glands. So just to show you the stretchability, this is only one study, it was just 6 adults. They gave these 6 adults who had somewhat of a limited motion to their tongue these exercises. And after just 4 weeks, they were able to stretch this tongue out anywhere from 10 millimeters, 20 millimeters more than we were able to before, or 40 millimeters. You can even get these little exercisers called tongue gym for children. So again, it's a very stretchable area. And like I just said, there's a lot of structures going on into this little membrane here. We think it's just a little piece of mucous membrane and you just cut it and that's it. There's a lot of things going on in that area. Also, there's a lot of different ways of describing the attachments of these frenums. It's also associated with a lot of other connective tissue disorders, such as Ehlers-Danlos, oral facial digital syndrome. You can also have the lingual, either an anterior attachment, and this is where you see that heart shape or V-shaped tongue tip, or you can have a posterior attachment. You also can have buccal frenums, as you know, both in the mandible and in the maxilla, both anteriorly and also posteriorly. The tongue itself is a changeable structure. It's called a hydrostat, kind of like an elephant's trunk, kind of like an octopus tentacles. So just a little example of what that would look like. So here's a water balloon that I'm pressing on. So you can change the size and shape of this tongue depending on what the patient wants to do with the tongue. So here's the same patient, happens to be me, so I know it's the same patient, with different results. So you tell the patient, you want to examine the tongue, you want to examine the frenum. Open your mouth and let me look at it. So the one on the left looks like a normal tongue, fits within the lingual surfaces of the lower teeth, and the one on the right looks like macroglossia. Same tongue, same patient, just interpreting what you're telling them to do differently, or stick your tongue out. Then you want to look at the frenum. So you tell the patient, take your tongue, put it up to the roof of your mouth. Here again, especially with children understanding you, what that actually looks like, just on a visual examination. So in the 2010s and later, people started looking at how can we physically identify what is a tongue tie, what is ankyloglossia. So you had both Martinelli and Marchesine do this more from a functional and historical parameter, doing a lot of measurements and so forth of the tongue function and what the child was actually doing. Unfortunately, that took them anywhere from a half an hour to 60 minutes, not something that's very feasible in a private practice. The one that you'll see a lot of is called the Cutlow measurement. This is a pediatric dentist who did a study with about 300 children and determined that what was the normal measurement from the tip of the tongue to the insertion of the frenum. And he came up with a measurement of 16 millimeters. Ruffolo did the same study following Cutlow's example and came up with 20 millimeters. So here again, using the same type of measurement, you get a different parameter. Hasselbacher did it using doulas and determining breastfeeding issues and so forth. The one that's really made a significant influence is the Stanford group, and you're all possibly familiar, those of us who deal in sleep medicine, with Dr. Guilleminault. They did a tongue range of motion ratio. So here they take the patient and have them open their mouth as wide as they can. They do that interincisal measurement. Then they tell the patient, take your tongue, put the tip of the tongue to the roof of your mouth or behind your front teeth, and then open. If they can't open more than 46%, that's considered a tongue tie. So this is what that looks like. So as you can see in this one over here, what they're doing is taking this flexible cardboard ruler called a quick tongue tie assessment tool. Those of us who deal in TMJ issues probably recognize this as the range of motion when you're looking at patients' lateral movements and protrusive. So again, what you're doing from the insertion of the frenum to the tip of the tongue, that's the measurement they're looking for. Then again, the Stanford group, headed by Guilleminault, did this tongue range of motion ratio. Again, where you're seeing them have the patient open fully, do that measurement, and then take the tongue, put it to the roof of their mouth, and so forth. And again, like I said, 46% was at what they considered minimum opening. However, this was a single unblinded rater that did the study. And again, you can see this quote, analysis based on a subjective clinically significant ankyloglossia. So one of the researchers, one of the great researchers out there is an orthodontist named Dr. Audrey Yoon. And she gave a lecture one time that I attended talking about this topic. So I sent her an email, as you can see up here, and I said, what do you do in a private practice? What do you do for your patients when you decide whether you're going to do a frenectomy or not? Both in terms of sleep disorder breathing and in terms of growth and development. And very kindly, she wrote back to me. And she says, I look at tongue function. The last thing I'm going to do is a frenectomy. I may do maxillary expansion. If need be, I may do myofunctional therapy. But the last thing I'm going to do is a surgical correction. So this is out of the same group that I just showed you before. And so like I said, Christian Guilleminault is one of the fathers of sleep medicine. And he's one of the ones that have actually promoted this theory of maxillary expansion, especially in children, being one of the reasons to help children in sleep disorder breathing. Unfortunately, a lot of his research, he combined TNAs with maxillary expansion, with other things, so it's all kind of combined together. But in 2015, this is what I think really increased the reason patients are coming to you, and you're seeing dentists doing a lot of frenectomies. This is his first study, very small study, 27 patients. And again, he never really mentioned how he diagnosed the short frenum at that time. And he followed these patients, and he came to the conclusion, just based on whether the child was snoring, poor sleep, fatigue, that a short lingual frenum may lead to abnormal orofacial growth and a risk factor for sleep disorder breathing. But again, if you look into the paper, if you look into the study, that unless you did a TNA and or orthodontics, that doing a frenectomy really didn't make that much of a difference. He followed this up with a much more rigorous study. This time, he actually did do an overnight study, a large number of children, 150 children, 3 to 12. And again, he used both the Cutlow measurement and the tongue ratio measurement, motion measurement. And he divided these children up into short lingual frenum and the normal lingual frenum. And he came to the conclusion that a short lingual frenum caused a higher AHI. But again, if you look into the study, it was just mentioned before, with children, the ratio of male to females for obstructive sleep apnea is 1-to-1, as opposed to adults where it's 4 males to 1 female, that only the males were higher. And what we go by sometimes more is the average oxygen desaturation. And as you can see, there was really no significant difference between males and females that had a short lingual frenum. So let's go through a couple later studies after Dr. Guilleminault's study. So this is one, a very large study, 504 children. They came up with a very high percentage of these children having a short lingual frenum, 22%. As you'll see in most of the literature, it's closer to 1 to as much as 5%. Now what they used was the Cutlow method, as I mentioned before, and they used a questionnaire to determine whether these children had significant sleep disorder breathing. It was sort of their own questionnaire, the SCR. Nobody I know outside of this group uses that questionnaire, and what's called the Brulette score. Here again, they found that a short lingual frenum in children were higher at risk for a positive SCR. Again, this is a questionnaire compared to normal. Another study that showed pretty much the same thing. This one used a more validated study called the Pediatric Sleep Questionnaire, where you can see there were 67 children in the high predictability of having sleep disorder breathing and 68 in the control. They used that quick tongue tie assessment tool. Here again, they came up with only 16 children with a short lingual frenum in the study group and 4 in the controls. However, because of that, they came up with a conclusion that 5 times more likely to have a higher score in the PSQ than those that didn't have a short lingual frenum. This is one, unfortunately, is the whole thing coming out there? Oh, good. So this is the latest study that I was able to find, a much more rigorous study. So this is a randomized double-blind study, 32 children, again, using the quick tongue tie assessment tool and doing an overnight sleep study. And they had divided them up, 16 with myofunctional therapy only and 16 with myofunctional therapy and laser frenectomy. You can see that the study group, the ones that were more severe than the control group, they got a greater reduction. A lot went from severe to mild by doing the frenectomy as opposed to just doing the myofunctional therapy. But again, if you look deeper into these articles, so we're talking about cutting the frenum, increasing the range of motion of that tongue. That Cutlow score was the same before they did the frenectomy as it was afterwards. They had the same mouth opening, and they were both equal in both books. So my question is, if the parameters of ankyloglossia were improved in both the myofunctional and the frenectomy, why did the physical things be the same? So one of the things, if you're interested in this topic, is Dr. Carol Marcus's study back in 2013 called the CHAT study, where she had over 500 kids all having an overnight sleep study, all scheduled to have their tonsils and adenoids taken out. Half of them had the procedure done. The other half didn't. In 6 months, close to 50% of the non-surgical patients resolved their obstructive sleep apnea. So the question gets to be, how much did this frenectomy, in this very good study, by the way, actually accomplish? So let's go back to that original marketing slide of the tongue tie centers, where they said that the base of the tongue is, because your tongue is held forward, the base of the tongue is going back. So again, if we look at the congenital retrognathic individuals such as Treacher Collins or Pierre Robin, what do you do with these babies when they're born like this and they can't nurse and they can't breathe? You tie the tongue forward. You don't tie the tongue back. You bring the tongue in a more forward position. So again, the rationale for what they're doing, I'm not sure has a real good basis in fact. The other thing, if you go, because of this increase in the amount of frenectomies, there have been a number of so-called white papers, first by the ENTs, that showed at the end of their review of the literature, there's no evidence that ankyloglossia causes sleep apnea. Your own group said procedures are not supported as treatment to prevent future OSA, and even the American Academy of Pediatrics, evidence is sparse in the management of obstructive sleep apnea in children. Even breastfeeding, even the National Association of Breastfeeding came out also against doing frenectomies as the first option. In fact, one of the things that's also being promoted is not only doing lingual frenectomies, but doing maxillary buccal frenectomies to improve nursing. And that's probably going to have just the opposite effect, because if you release those buccal frenums in young children, you're probably going to decrease their sucking ability. Let me switch gears and talk about the second topic. How does ankyloglossia affect the growth and development of both the maxilla and the mandible? So I'm going to go through 6 studies that actually looked at this. So this is one study, 57 subjects, little older patients, 19 years of age, again, using that Cutlow method as a determination. They found that those that were considered to have ankyloglossia in the Cutlow method were more class 1. They did find more maxillary deficiency, both not only in the intermolar width, but also in the maxilla itself. And that was their main finding with that. Another study, again, the Stanford group did 302 orthodontic patients. Here they not only used the Cutlow measurement, but also that tongue range of motion ratio, cephalograms, CAS measurements. They did find a decreased intercanine width with the ankyloglossia group as measured by their measurements, but not an intramolar width difference. Soft palatal length, they did not find an association between skeletal or dental angle classification with restricted tongue mobility. And here again, getting into how many of these children were actually diagnosed with ankylosing, basically only 1% of these children using that method were diagnosed with ankylosing. This is another study, 4 to 14 years of age. This one they used the functional analysis that was developed by Barchason. And what they found that a short lingual frenum was found in 48% as opposed to 24% in what they considered malocclusion. And the most significant malocclusion was class 3 with the short lingual frenum. Next study, 150 individuals, again, more of an adult. This time they just used a ruler, pretty much similar to the tongue range of motion that I was mentioning before in a cephalometric analysis. Here again, they found more class 3 using that kind of determination. This study had 30 patients. They had 10 of class 1, 10 class 2, 10 class 3, and then they used CAST to measure whether they had a short lingual frenum or whether they were tongue-tied. Here again, they found that short lingual frenum was more in the class 1 occlusion and longer in the class 3. The last one, 700 patients, 7 to 17 years of age, using that Cutlow diagnosis and visual angle classification. Basically, they found, again, only 1% of these individuals using that technique had ankylosing. Here again, they found it more in the class 3 individuals, but they did find more maxillary constriction, anterior open bite, and lower anterior crowding. So we take all 6 of these studies, and those are the only 6 that I could find that looked at this business of ankylosing and malocclusion. You can see that 4 of them had class 3, 1 of them had class 1, and 1 there really was no difference at all. 3 of them that actually looked at maxillary constriction and ankylosing, 2 found it, 1 didn't. And again, like I mentioned before, only 1%, when they looked at the prevalence, the incidence of ankylosing, was only about 1%. In relationship to whether ankylosing has any effect on maxillomandibular advancement changes, the American Academy Association of Pediatric Dentistry came out with their statement that the evidence has showed that ankylosing and abnormal tongue position may affect skeletal development and be associated with class B occlusion is limited. This is an interesting child that I saw a number of years ago at the sleep clinic at Children's Hospital. There's a very rare condition called Hanhart syndrome, where you might be missing digits, you might have webbing between your fingers. One of the interesting things about Hanhart syndrome, you may be missing part or all of your tongue. So this is a child, and you can see form and function going together here, where she doesn't have a tongue at all. The parent refused to have any kind of surgery whatsoever in order to try to correct this. And they asked, of course, for my opinion, and I said, well, the orthodontist needs to get involved with maxillary and mandibular expansion. So when I was preparing this talk, it came to my mind, whatever happened to this child? So I called the pediatric dentist who referred her to an orthodontist. Do you still have records on this child? So you can see the constriction both in the mandible and the maxilla, and then 8 years later, and again, she had no surgery. There was no either orthodontic surgery or chin implants. So even doing regular expansion orthodontics, you can see how stable the maxilla is. The other interesting thing is if you look at the mandible, mandibular growth did take place even without the tongue. So in summary, we have 8 different methods to measure and quantify what is considered ankylosing, either based on a measurement or functionality with limited or no agreement among any of them. And every medical and dental association involved in whether ankylosing is a cause or an aggravating factor in either sleep disorder breathing or malocclusion either firmly say it is not, or there's limited evidence in this regard. So in conclusion, assessment of ankylosing is primarily based on the functionality of the tongue, not the length of the frenum. Frenectomy, in my opinion, is the last option, not the first option. whether you're talking about speech problems, breastfeeding issues, obstructive sleep apnea, or malocclusion. And although frenectomy is a relatively easy procedure to perform with really small sequelae, as a dentist, what is your liability if there's an untoward event based on the organization's cited white papers? Actually, I have a slide that we had from Children's Hospital from the ENT where a dentist performed a frenectomy on this child. The child moved, lacerated the whole lower floor of the mouth, and had to have that surgically repaired. So even though the incidence of an untoward effect are very low, it can happen. So again, in looking at topics, what I like to tell my residents, and when I'm giving a lecture, sometimes you just need to take a look a little bit differently at the research and some of the articles that are out there and some of the theories that are out there. So like these meerkats in the Kalahari Desert, the reason they get up on their hind legs is to get a better look at the raptors that are coming after them. And if you're a dumb tourist like me and stay there long enough, they'll eventually climb up on you. And I'm open. Thank you. So we have a few minutes. If anybody wants to ask any questions, be happy to answer. Yes, ma'am. These lights are in my eyes and I can't see that well.
Could you comment on the different ways or do the tongue tie release?
Say again, please.
The surgical forms, they have all different types of surgical relief, surgical method for tongue tie relief.
Yeah. So with the ENTs, at least at my hospital, especially with the infants, they're going to want to do this, number one, under general anesthesia. They don't want that child moving at all. Number two, again, they have to go through everything else, whether it's speech therapy, whether it's a doula going for breastfeeding, whether there really is a significant problem as far as the tongue. And I have not seen it, by the way, in sleep disorder breathing. So what you're seeing mostly in private practice is a laser being used because either the mother wants it or the dentist wants it and so forth. It's generally being done primarily by pediatric dentists, but there are some ENTs that are also, you can talk a surgeon sometime, you can talk a person sometime into doing anything. I don't know if that answers your question or not.
There was one called Frenoplasty. One surgeon in California promoted this procedure. So I don't know if you have any comments on that.
I don't. Well, thank you very much. And if you want to ask me any other questions, I'll be more than happy to.